So that is, as you know, that's Natasha, Siki, that's John. Do you all want to just check your audios before we start, just to say? So, John, you want to say, are you okay?
Hello, Suji. Yes, can hear you clearly. Can you hear me?
Yes.
Yes, we can hear you.
Good.
How is the weather, Alan, in Massachusetts?
Well, today it's suddenly gorgeous. It's about 72 Fahrenheit, which is about 23, 24 Celsius, clear blue skies. It is not normally like this this time of year, so we're enjoying it while it lasts. How is it there?
The wind blew itself overnight. Oh, it was pretty bad. I woke up with wind blowing. It's pretty dull. It was pouring today in Cardiff, Wales.
Well, that's pretty normal for us.
Okay.
Yes.
And wet.
Yeah, we're normally having mud season about now, so it'll be raining again soon, I'm sure.
Can you increase the volume, yours, Alan, please?
Oh, let's see. Let me
that's that. Yeah.
Go check my settings.
Hi, Siki.
Hi, can you hear me okay?
Yes.
Good.
That's the layout for today. We hope to finish. We hope to finish by 8:30. It's almost 2 hours. How long do you have time, Alan?
I can go for an hour and a half, so till 3 o'clock here, which would be 8 o'clock your time.
That's fine. Thank you. Let me see. Chandler. Hi, Naresh and Donna, Medusa, Dr. Hi, Dr. Baig.
Evening, Sujata.
Hi.
How are you doing?
How are you?
Okay. Plodding along slowly.
Sorry, I can't hear you.
Plodding along slowly. This damn weather has got my fence down on one side of my drive. So it's blowing a gale again out here. So after hearing what Alan is saying over there, I just want to hop on a plane and get down there.
By the time you got here, our weather would probably be much worse already.
No. I'll have the tailwind with me.
Right.
Hi, let's start now. Good evening, everyone, and thank you all for joining. The event, A Year On with Pandemic, is being organized by the Mentoring TMR, a charity based in Wales. Our charitable objectives are to promote social inclusion for people who are socially excluded through a variety of means leading to disadvantages, in particular through ethnic and cultural background, poverty, geographic isolation, and health issues. At the Mentoring over the past year, we have worked to support the people suffering from the economic and social impact of the pandemic, helping vulnerable people through mentoring and engaging them in activities to cope is our first priority at the moment. You can see more details on our projects, workshops, mentoring activities, and you can find it on www.mentoring.org.uk. Since the WHO, that's World Health Organization, declared the global outbreak of COVID-19 on March 11, 2020, the world and our lives as we once knew them have changed dramatically. We are very delighted to have you all participate in tonight's event to discuss what we all have experienced, learned, and what we can think about our future and it may look like. We also understand how hard it is for those who lost members of the family, friends, neighbors, and colleagues. Some of you must have made use of this lockdown in terms of time and skills as simple as running faster, learning a new language, or starting that side hustle, or even mastering the perfect sausage roll. So our beneficiaries we call friends of TMR. I can see a few of them online here today, and some will be sharing their stories. So please stay back and listen and enjoy your evening. I'll pass it on to today's moderators of the evening, Siki and Natasha Taladi.
Hi everyone. So before we get started, I'm just going to go over some ground rules. So firstly, we have muted everyone by default, so we won't be disrupted by mobile phones. By joining the event virtually, you're giving consent for this event to be recorded. This might be shared on our social media platforms such as YouTube, Spotify, and our website. So if you prefer not to be recorded, you can turn your camera off. To ask questions, you can use the chat option on Zoom. We will be monitoring this and we will ask the questions raised at the appropriate time during the event. And if your connection drops at any time, you can re-access the session using the original Zoom link we sent. I will now hand it over to Natasha, who will provide some context about the structure of the event.
Hello everyone, and thank you for joining. We're really excited to have various speakers sharing their stories over the last year today. So Siki and I will be interviewing the guests this evening. And I'm delighted to introduce our first guest of the evening, Dr. Alan Duff. Alan has a PhD in microbiology from Sorry, can you hear me?
Yes, we can hear you.
PhD in microbiology from University of Columbia. Alan previously worked in laboratory research and he left that to become a science journalist. His work appears in numerous publications and he's currently one of the hosts of Microbe TV and blogs at Turbot Black. Alan, so our first question for you today is, can you tell us about what your experience as a science journalist during COVID-19 has been like?
Well, bizarre would be the word that would come to mind. So it's a very strange time to be living for everybody, and it's a very strange time to be a journalist, especially a science journalist with a background in virology. And as I'm sure people know, there's been a lot of attention to news about viruses, and there's been a lot of information and a lot of misinformation and even disinformation going on in the field, which has been very strange to watch for somebody who has for a long time covered this field and hoped that people would notice. Most people don't think about viruses, or before the pandemic, they didn't think about viruses on a regular basis. So in one sense, it's kind of been I guess a little nice that people have noticed that viruses exist and that they have interesting biology. I wish that could have been accomplished in a less destructive manner. And at the same time, I mean, the amount of passion around this issue is obviously very high. The amount of politics around it is rather disconcerting, and I've spent pretty much the past year doing various assignments. Initially, it was pretty much anything that wasn't related to COVID-19 was just set off to the side. And nobody was even covering those stories because nobody wanted to read them. they about 6 months in, finally the regular science news that I do started to reactivate, and those stories came back up into my agenda. On the podcast that I co-host, This Week in Virology, we were all SARS-CoV-2 all the time, from really from about February of last year. So we were into it before it was cool, so to speak, and have then spent several months where we had no episodes about anything else. And traditionally, our podcast has been about all kinds of viruses, and there's so much to talk about. So that narrowed our focus a lot. And just recently, within the past couple of months, we've slipped in a few episodes that talk about other viruses. We've had a huge increase in listenership as a result.
Sounds like a very interesting, busy year for you.
So earlier you touched on the point that there's been lots of misinformation. What do you think about the way the news has been handled and mishandled across the course of the pandemic? And what do you think the direct effect of that had on the viral spread?
Well, that's a great question. In terms of the direct effect on viral spread, it's very hard to measure. But in terms of the coverage, I think a lot of people in my business have been trying very hard to get the stories accurate, in the context of information that was not complete. So early in the pandemic, there was a lot we didn't know, and it's difficult as a journalist to cover stories where you talk to experts, you talk to your sources, and it's not that they don't want to tell you what's going on, it's that they don't know. And of course, scientists will be very circumspect about that and are very direct about that, and will say, hey, we don't know this, and there's a probability of this and a possibility of that. But it's very hard to write those stories for an audience that wants the news right now, and it's got to be brief and punchy, and there's a big focus on that. At the same time, we have this whole social media landscape that has played very heavily into the misinformation and disinformation. And there are, of course, a number of entities, organizations, even governments that have tried to advance falsehoods and have succeeded in doing so by making inflammatory claims online, on Facebook, on Twitter, on these types of platforms, and amplifying them. And I think it was Mark Twain who said, "A lie can get halfway around the world before the truth can get its shoes on," or words to that effect. So it's really a lot of the news and a lot of the journalism this year has been trying to catch up to all of the misinformation that's been put out through other channels.
Does anyone have any questions for Alan from the audience at all at this point?
Right.
Chanda?
Yeah, we talk about misinformation. What I'm concerned or would like to know is whether misinformation is same throughout the world, or is it different in UK and different in America? And if there's any misinformation, we've got World Health Organization. They should be scrutinizing what information is going out to the world because of the internet, and not that I'm very good at, FaceTiming or Zooming or anything. It can spread very quickly. So short and sweet, misinformation, is it different, or what sort of are we talking about, Alan?
Well, a lot of people who study this make a distinction between misinformation, which is maybe well-intentioned but not correct, and disinformation, which is has malicious intent and is deliberately constructed to deceive. And I mean, I can't really speak too much to the international experience because I've only been, I live in the United States, and for more than the past year, I haven't gone anywhere else for reasons that should be obvious. but I do know that certainly having, for example, a president of the United States through the majority of the pandemic who was actively promoting, in many cases, misinformation and in some cases disinformation, was extremely counterproductive. And so you point out the World Health Organization, they are very constrained in what they can do, unfortunately. And yes, there are a lot of people who work there who could help with this, but when you have a powerful actor like the United States either not participating or actively working against the interests of the truth, it is difficult, if not impossible, for an international organization like that to stop that process. So I'm not sure what the solution is there. I mean, the solution we applied here in the United States was to vote that guy out of office, thankfully, and so now we actually have responsible management. I think in a number of countries around the world, there was this problem of different branches of government maybe having different agendas. In the U.S., we have this this federalist system where we have the federal government, then we have 50 states that have their own governments, and since the federal government at least until January was essentially absent from the pandemic response, all 50 states came up with their own responses. So I live in Massachusetts. Massachusetts had its own way of doing things. Connecticut, just down the road, had, right down the block. I can bike to Connecticut and be under a completely different set of, not completely different, but different set of rules for COVID-19. So that lack of coordination was a big factor. And I know our case may be unusual because of our federalist system, but other countries have had other situations like that where the local response maybe didn't quite jive with the national response. And I think that that played into a lot of the misinformation that was floating around, where government entities may have been misled and did things in different ways.
I can imagine, yeah. We've only had 4 different, in United Kingdom, 4 different sections, and you've had 50. I can imagine how vast that problem must have been. But thanks for highlighting about, bringing that point out, that it's not easy.
Thank you, Chandler. Shall we move on to the next question?
Please, yeah.
What's the best advice to give to a person who's against vaccines?
Well, I wouldn't give advice per se. I would first of all find out where they're coming from. So there are people who are just opposed to vaccines for various reasons. There are some religious denominations that specifically say, we don't want vaccines. That's a very hard objection to overcome, because I'm not a theologian and I'm not their clergy, and I'm not going to be able to get past that. I think that's relatively rare. A lot of people who are hesitant about vaccines or skeptical of vaccines are actually just unsure of whether a particular vaccine is a good idea. They've heard various things, and online you can find all sorts of arguments that range from kind of okay to outright insane about vaccines, and people will be confused by all this information. And in those cases, it's very useful to just have a conversation in which I would say, well, what's your experience been with vaccine? Were you vaccinated as a kid? Have you ever had the measles? Have you known anybody who had polio? And you can get to a point where you're having a meaningful conversation. And I think that's an important first step. And from there, move on to addressing their concerns. And in a lot of cases, it turns out, as a scientist, what I reach for are the data. Look at these graphs and charts and see how impressive vaccines are. It's one of the great medical accomplishments of humanity. But it turns out that what really carries a lot of weight in these types of conversations are personal stories. And, again, as a scientist, that's not That's not what I would reach for immediately, but a lot of research that's been done on this says it's much more powerful for somebody who's hesitant to get a vaccine or hesitant to vaccinate their child. Much more powerful for me to say, well, my kid got her flu shot and I got mine. And that people will say, hey, wow, this guy really, he puts his money where his mouth is. He's serious about it. And everybody in the household is fully vaccinated, and well, obviously we don't have a pediatric approval for the COVID-19 vaccine yet, so my daughter hasn't had hers. But I would certainly, for this vaccine, I would say take the approach that this is a vaccine that was developed in a process that went a lot faster than usual, and people are I think appropriately a little bit leery of that, right? I mean, everybody was saying at the beginning of the pandemic, it'll take 2 years to develop a vaccine. Less than a year later, we've got one. But I think the conversation to have there is around how that was accelerated. And the answer is not that we took shortcuts. The answer is we poured massive amounts of money at it. So things that would normally have been done sequentially were done simultaneously. And so that was really the key. These are safe vaccines that were developed through using all the normal protocols, but it was accelerated with money. And so that's the way I would begin to address that kind of hesitation.
Thank you, Alan. We've got a couple of questions here. Is it true that the effects of COVID-19 has been over politicized for political gain? And a couple of questions as well, so we may have to go a bit further.
Okay. Yeah. So I would not say, well, if you mean the effects of COVID-19, if you mean the deaths, those are real. People died. In this country alone, we lost over 500,000 Americans, and we still have people dying from it. If you ask around, you will certainly encounter people who have lost friends and relatives to this disease. It's real. Has it been politicized? Well, I think there was certainly an early move by many politicians to downplay it. And again, going to the US example, we had a particularly prominent COVID denialist who was running the country for most of the pandemic. And I think that caused a lot of trouble because it created this divide between people who believed him and people who believed the science. And the science is not political. It's just we've had politicians who are opposed to data because they don't like what the data say. And so that is not a political issue. This is a virus that kills people. It is true that 99% of the people who get it are going to survive. But if you're in that 1%, that's game over. And we now know that certain people are much more susceptible to that, but nobody is perfectly protected. And, you say 99% survival, well, I'll just take my chances. Well, would you really? If you get on an airliner and the pilot says, we're expecting a safe flight today, I'm 99% sure of that. Are you comfortable flying like that? Because I sure wouldn't be. So yes, this is a deadly virus. I don't think its impact has been exaggerated. I do think that there's been a lot of politicization of the response to it, and I think a lot of that has stemmed from many politicians not liking what the facts are and trying to put the facts to a referendum, which just doesn't work.
Going off what you just said about 1% of people dying, why do you think that COVID is killing more people of color, especially in Western countries, when there's been fewer deaths in Africa, India, for example?
Very, very good question. So the international comparisons, one of the big things, and this I can't really speak to other countries' perspectives because I'm not deeply familiar with the ethnic divisions in various places, but certainly I can speak to the U.S. perspective. And as obviously a white upper middle class man, I'm pretty much on the protected side of everything. But in the U.S., we have a large population of African Americans who have had extremely high rates of COVID-19 deaths. And initially, people were saying, well, maybe it's something that's genetic. But my first assumption when we see something like that, especially with Black versus white Americans, is that this is probably due to structural racism, which is something we know we have. And in fact, as soon as you look at it, and I've been covering health disparities as one of my various topics because public health is part of my beat. I've been covering this issue for 20 years. It predates COVID-19. And what you see is not some kind of genetic secret to why African Americans are less healthy on average than white Americans. What you see is that through being segregated into particular neighborhoods that have less access to outdoor areas for recreation and exercise, that have less access to healthy food in the grocery stores, that have, overall lower incomes. You have all of these problems that stack and that synergize to cause obesity and heart disease and the whole set of things that go with being disadvantaged. And so, yes, African Americans are dying at higher rates of COVID-19. But if you look at the data, you see that that's because African Americans have higher rates of obesity and heart disease, et cetera, and asthma. And all of that is a direct result of the racism in the system that has caused these systemic disparities. Whereas if you compare to, say, most countries in Africa, where the majority is African, obviously, because they're in Africa, they don't have that. There is in many countries in especially parts of Africa, there's endemic poverty. They have a lot of issues surrounding that. But they don't have that kind of structural racism affecting the same people. And there are other issues there where that could easily explain the death toll difference. Some of that is record keeping. A lot of places may not be keeping as close track of COVID-19 tests. SARS-CoV-2 testing is not up to the same speed there. There's also an issue of demographics. One thing that we know absolutely clearly with this virus is that the older you are, the more likely you are to have severe complications. And so if you have a country where the median age is much lower, you're going to see much lower mortality.
Thank you, Alan. I think Sunil had a question as well. Sunil, are you still there?
I don't think he has by accident, he had turned, he raised his hand by mistake. So you can carry on.
Okay.
Thank you so much, Alan, for speaking. We're going to move on to Almero. Almero is currently the head and chief manufacturing officer for a biotech company which prepares commercial marine collagen. So this is a question for you, Almero, and also Alan, feel free to chip in. Do you think scientists should attempt to counter misinformation across fields that they're not particularly specialized in, or do you think they should stick to their own discipline?
As a non-virologist, I'd start, I guess, Alan, and just say, I think we have a duty to try and share and spread factual information, as long as it's in the right context and as long as you've done your homework. And say if you don't know. The worst is having someone on that is a doctor in this, that, and the other, and they've like everybody's mother had a PhD from Facebook in virology, and they have an opinion, and just because they're a doctor, they're taken seriously. But yeah, I've felt that there's a big gap and a need for scientists to step up and share factual information, and it's inborn typically into scientists to try and stick to the facts and not have too much of an opinion, or be very clear, as Alan and the team is or are on TWIV, when they have an opinion, that it is their opinion based on what they've got as background, and typically from a very well experienced crowd that is focusing virology. So in my personal experience, I've had numerous occasions where I've spoken to people in the community, my butcher, that have had completely missed a lot of bad information. And one of the things that I've read, apart from knowing most of what I know about virology from TWIV and Alan and the team, even though I am a biologist or a biochemist, it was really important to try and get an understanding from of where the person came from, or the background around the problem. The big question in the case of my butcher was, or the circumstances were, the fact that they had to be shut down, and that was their main source of income. Coming out of it, they were obviously in a critical situation, as with many other companies. And when you're in that desperate need for some information, and what you have as a platform is not TWIV, that not everybody knows about. Luckily, more people know about it. And you have Facebook, where you are, these days with AI, also directed to what you start searching. It's really, really easy to fall into a rabbit hole or two. So yes, long-winded saying yes, as long as you say when you know and you say when you don't, and quote a few references.
Yeah, I would agree with that. And I mean, in my case, it comes up when I've covered public health as part of my beat for 20 years, so I have some knowledge of it, but I am not a public health PhD. I'm a PhD in molecular virology. And so when I get deep into some discussion of statistics, I will qualify and say, I'm not really a public health statistician, and qualify that, say, but what the statisticians are saying is this, and I will trust their interpretation, and refer somebody to them.
Yeah.
Thank you, Alan. We've got a question from Bilal for Elmiro. So, as a biologist yourself, and seeing the recent blockade of vaccine export from EU to Australia, how do you think we can make vaccines more accessible for developing countries? And why can't we share material and methods and help these countries develop the vaccines themselves?
I think there's a longer history of the majority of vaccines being made in core sites. Again, not my background to highlight the disclaimer, but we all know about the Serum Institute in India that does the majority of vaccines for the world. And that's typically been the case historically for, most vaccines. So countries like Ghana, that's just recently received the first doses through Gavi, I think, where there's a distribution of vaccines to countries that can't afford their own. I'm pretty certain, but going out on a limb, that Ghana would not have the infrastructure to make their own. The problem with sharing technology and trade secrets is a difficult one. But I must say that I have seen that more recently, in the last 2 months, the big pharmaceutical companies that obviously get bastardized a lot about trade secrets and IP and not being forthcoming have started working together. We're all in this together, and there's been a number of companies, in particular companies that didn't have successful vaccine candidates, that have opened up their doors and said, hey, look, we've got capacity. We can make a few 100 million or maybe even 1 billion doses, but we don't have one to make. So we will subcontract from you and work together to get it to the rest of the world. So there is some sharing of the recipes and the likes, but yeah, at the end of the day, it's still a very difficult thing to do.
Thank you, Amira. So our next guest speaker is Dr. Baig. Dr. Baig is a senior medical practitioner and also a hospitaller and trustee for St John's, Cymru, Wales. Our first question for Dr. Baig is, what were your experiences as a GP over the last year and the impact COVID has had on your services, staff and patients?
Sorry, you're on mute.
Am I still on mute?
That's me. Thank you, Tasha. The way general practice in the UK, or particularly Wales, where I come from, is provided has considerably changed since the pandemic. The pandemic for me particularly has been a very, very, very frightening experience. As we are classed as frontline workers, we see patients face to face, and we don't know who's walking through the door. There's been a constant fear and a worry of catching the dreadful disease. I remember the first week that I was there, my second last patient that walked in had symptoms typical of COVID. I had to examine her, take her history, examine her, and I had to admit her into hospital. I was not privileged with any PPEs. You can understand what I went through when I arrived home. We had to get a team of sanitizers in to sanitize the whole surgery. Waiting for my test to come back was another nightmare. 5 days I had to wait for my results to come back. There were the infancies when tests were being done and we couldn't even get the tests. I had to fight my way into getting one. 5 days was agony, believe you me. I've never prayed so much in my life. One can only experience that moment when such a thing happens to you and you kneel before God to say, God, help me, save me. I hope it's negative. I think I must have done something good in this world. It was negative, thank God for that. But believe you me, every day, every time I go to work, my heart is in my mouth. I don't know who will be there. Who will I meet? Am I going to come back with COVID or not? But talking about general practice, that was my person. I'm still frightened, scared, worried, you name it. I've had that experience. Now, lockdown has made us provide the general medical services very differently. Majority of our staff had to work from home. We had to invest thousands of pounds buying laptops, equipment, etc. for the staff to work from their homes. We have 3 sites. From one site, we just triage patients. That's a clean site. From this triage site, patients who do not have COVID are sent in to be seen by a GP. That is a semi-clean site. A third site that we have is a site where we suspect patients suffering from COVID. We send them there. The GP and the staff there are all cloaked in full gear. They look like astronauts when they are examining the patients, etc. Majority of the diagnosis is correct. Thankfully, as vaccination is taking place, less and less cases are coming up. Majority of the patients are sorted out by the clean site when the doctor telephones, speaks to the patient, etc. If necessary, if they require, it is required to be seen. There's an appointment made straight away for the patient to be seen in the semi-clean site if they are non-COVID patients. But majority of the patients have got trivial complaints, trivial ailments, etc., that can be dealt over the phone. Prescriptions, patients are not allowed to come to the surgery to collect. These are all faxed through to the chemists, where the chemist, they can attend the chemist and get the prescription, or the chemist delivers them to people who are who are under lockdown, or who are shielding or isolating, etc. From the clean site, we also have 2 or 3 other practitioners. One is a nursing practitioner, and one is a pharmacist who deals with various items of, for example, repeats prescriptions. If there needs to be a referral made, we do that from that side. All test results that come in are, we either communicate to the patient by email or by letter. If the patient needs to be followed, an appointment is sent accordingly. There have been a lot of plus points and negative points from this COVID. The plus points, patients have consultation the same day. Patients can consult from the comfort of their own homes when the doctor telephones them. They do not have to take any time off work. They can, even when they're at home, they can excuse themselves when the call comes in and speak to the doctor, who can, majority of them are sorted out over the phone. Like I said earlier, all results are sent to them by email or by letter. Again, repeat scripts are done in a block for patients who are stable, block of 3 months at a time. They are sent to the chemist, who delivers to these patients on a monthly basis. These are our patients that I'm talking who are stable and are on repeat medications. We also started an e-consultation, and this has been a little bit of a pain for us, because now the most trivial of things are coming through the e-consultations. Particularly so on a Monday morning when we go in, there are, over the weekend, there'd be 200 e-consultations waiting for us. This is time consuming. Now, these were the little positives and negatives I'm going to talk about. The staff are working from home. Doctors fear missing a diagnosis when you really are talking to a patient on phone. It can happen to the best of best physician. Patients sometimes do not explain properly. When they're not examined, things can be missed. So this is a dilemma that we have and we are all facing. We've had abuse from some patients, not us, the practice, the triage staff that take the call. Some of them are very demanding. We want to see the doctor face to face. The doctor will telephone you, but they are abusive. This abusiveness has gone up 50%, but only there is a certain cohort of patients who do this. And we obviously, when we hear about such things, we write to them, tell them that such behavior is not tolerable. The other thing that we found, telephone consultations take longer. one has to, one who's not familiar with the patient, we have a list of 12,000 patients. Not all of us have seen the same patients. So we have to trawl through the notes to see, go through the referral letters, go through the investigation before we call the patient. That takes longer. So a 10-minute consultation, which is a face-to-face consultation which the NHS allows us, is now become a 25-minute consultation, 25-minute consultation. Waiting lists in hospitals are grown incredibly long because due to COVID, they're not seeing any cold cases at all. They are beginning to now. Some movement have started because of complaints, etc., etc. But this is how general practice has changed. Unfortunately, that's where we are. That's where we don't know when the lockdown is going to be lifted. But primary care, working of primary care is definitely going to change. There is going to be a certain element of e-consultation, there's a certain element of telephone triaging, but I, for one, I'm uncomfortable in triaging patient over the telephone because I'm a hands-on man. When I'm seeing patients, I'm happy. When I'm seeing face-to-face patients, I'm happy. But the frightening thing about it is COVID has left a mark on all us, particularly myself. I pray when I go out of the house to come home safe and pray on my way back. Thank God everything is okay. But that's how general practice is. That's how general practice has changed. For the better or worse, you will have to ask some patients as well what they are. But this is how we are. That's how we are operating.
Thank you so much for sharing such a personal and emotional story. Can you sum up in one sentence what your mantra has been over the past year?
Mantra, oh my God. I'm conquering my fears and becoming stronger each day. That's my mantra.
Thank you so much.
Excellent. Thank you very much, Dr. Beg. You've been very, very good. My name is Yasmin Khan. Sorry, I can't get my picture on. I'm not very good at it. So I was just going to say, how much all of you have worked really to the limit, which none of us could have done, I think. Thank you once again.
Thank you, Yasmin. We go to the next speaker, shall we?
Thank you. So our next speaker is Dr. Sophie Legrow. Dr. Sophie Legrow works as a GP for Holland Park Surgery in London and has a specialist interest in ENT and head and neck surgery. Hello, Sophie. Can you share with us your experience of working in the NHS during the pandemic and some of the challenges that you have faced?
Yes, hello everybody. Yes, I was actually on maternity leave when the pandemic started in March, and I returned in August. So I guess it had changed quite a lot during those couple of months, I think, and things were a little bit more settled when I returned. But having said that, I still felt like it was a completely different surgery to the one that I had left before I went off my maternity leave. Like Dr. Beg said, the joy of seeing face-to-face patients has largely been replaced now by telephone calls. And even though we can, of course, do video consultations, it really doesn't replace the human interaction that a face-to-face consultation offers. And I think that even when a patient does come in, it just feels really unnatural, an uncomfortable sort of, environment for the patient to come into because we're in full PPE and the patient's wearing a mask, and it's just not conducive to a nice environment for them. I also think that it has led to a lot of delayed diagnosis because a lot of patients have been either frightened of coming into the surgery to see us or have thought that they couldn't speak to a doctor. I think a lot of our patients have said that they thought that they were unable to talk to us, even though it was over the phone. So they delayed, contacting us about certain symptoms and complaints, which then has led to a lot of delayed diagnoses of cancer and chronic conditions such as diabetes. So that has been very hard. And I think the impact of that will be seen for a long time to come, actually. And also, just on a personal note, just not being able to really see colleagues, speaking to them on the phone rather than going to their room to talk about things like we normally would, not going into the staff room. It's really strange and not nice, but I think we've all got used to this sort of new normal, really, at the moment.
Thanks, Sophie. Yeah, that must have been so strange coming back from maternity leave to a completely different office. What motivated you or inspired you during those times?
Well, I think when I came back, I felt that the team that you could really tell that they'd been through such a lot, even though it'd only been a few months of the pandemic at that stage. And I think they showed great resilience, and I feel like the team is probably even more of a team now than we were before. But also the patients have, I think, on the whole, adapted incredibly well to the change in how we manage them. So I think the patients and my colleagues really have been what has inspired and motivated me during this time.
Thank you, Sophie. So my next question is, do you have any achievements that you would like to share with us today?
Okay. Well, I guess myself and my colleagues have had to sort of take more initiative and greater responsibility in a lot of aspects of patient care since the pandemic. And I think that we've done things right and we've done things wrong, and we've learned from it and collaborated quickly, changed things, which has led to definitely an improved patient care in a lot of ways. Also, we've been given a little bit more autonomy and control over some aspects, whereas before we were quite constrained in a lot of areas. So I feel that as a practice, we seem to be achieving more as a team really now than before.
Thank you very much. So our next speaker for today is Dr. Sheshagiri Rao. Dr. Rao is currently a consultant forensic psychiatrist and medical director for Thornford Park. Hello, Dr. Rao.
Hello. Good evening to all of you. Really enjoyed so far, very well. Very excellent information and personal stories. Thank you. Thank you for inviting me.
So you suffered from COVID last year, and at the same time, you also had to be a carer for your wife who had worse symptoms from COVID, whilst ensuring protection for of your two 12-year-olds. So that must have been quite challenging for you. Please, could you tell us more about the events and the emotions you experienced?
Yes. So I think like the whole world, and probably UK more than the world, is completely unprepared. I was totally unprepared. It's my probably 25th year in this country, and I worked all the way through, but I never called sick even a single day. I had a great pride in that. And when we were having these discussions from late February in my own workplace, we were making so many plans and contingencies, everything. What I never expected is I will be getting it. I never thought. I somehow thought I'm immune, because you never had any health problem. And all of a sudden, my wife 2 weeks later in mid-March said, I'm having these body pains and everything. I can't drop the children. Then I said, no, should I come and drop? No, so I said, no, let me go and drop. She went there, and in the evening also she took some paracetamol and went there, and she's described something like, these are the kind of pains I never experienced, the body pains. Then it struck a chord. Okay, something is happening. So I went there, brought her back, and I said, this looks like COVID, you need to go into isolation. And I had to go, I told my workplace, but I thought still I'm immune. Those were the times where we didn't have a very good understanding about social distancing. We didn't have any PPE. All they're saying is if you have symptoms, you isolate. Then after a couple of days, I had it. I mean, she's got a lot of risk factors, diabetes. So it's came as a complete shock. We just have to invent things then and there. There is no precedent. There's nobody to advise. So we have to improvise. We have to innovate, and we have to divide the house into two. Got the children to say that this is your part, this is our part, and we are caring for each other. I think mostly I'm caring for her, and we just had to get on. And the good thing is we got a lot of help from friends where they're dropping things at our doorstep. I think it was very challenging. It was initially it was shock, disbelief. You went through this kind of, then you just need to get on with that. I think somehow we were lucky because in hindsight, if we look back now, my wife's even I had very severe COVID, but I never thought in kind of any crisis or anything. But looking back at her, we just have to say that we are lucky. We somehow survived, and it was scary, but we are lucky. And I think a lot of it is we got a lot of support from friends, family, and people they didn't allow us to come down psychologically. That was good, and the children were fantastic. They're very understanding. They're not only at that time we don't know how much the children are affected, because one of our greatest worry, this is exactly a year ago, these are the times, we don't know how they're affected. Then the worry is if they get it, what are we going to do? But they did very well. I think as a family we're able to survive. There are other experiences, but again I will narrate as we go along about my experience with the NHS as a patient and things like that.
Great to hear that you and your wife are fully recovered. So yeah, earlier you were speaking about the fact that you had to innovate and come up with the resources as you went along. So since you had it quite early on in the pandemic, what services did the NHS have available at the time? Was anything lacking? We heard that you bought a pulse oximeter. Was that because of the lack of resources?
Yes. I think there are two things. One is, again, with all due respect to all GPs, this is all sharing. This is my personal experience. I'm not kind of generalizing, but we need to talk. Otherwise, if we don't talk, see, for the first time, I always felt, I was very proud to come to this country, to work in this country, to contribute to this country. For the first time, I felt the country was in a meltdown in March. Nobody knew what they were doing. And we take this wonderful pride that we have this world-class top healthcare system. And I felt in a third world country for a few days, I would get better medical care. Because I'll tell just 2 minutes on this experience. My wife was having this severe, unrelenting cough. And by the time I got the pulse oximeter and the pulse, they're dipping into mid 80s, and with some kind of support, she's getting into early 90s. It's a dire situation, and we had to call the emergency once, and they came, they stabilized, because they're picking up, they're coming into early 90s. At that time, that is okay, because there are other people who are worse than that.
Right.
So what we wanted is a benchmark. What is the limit? What is the threshold where we need to get medical help? Our first line of call is, we go to the emergency. If it is an emergency, they said, if you are having COVID, don't come. Don't come to the normal emergency. And they said there is something else, but there is nothing at that time. That is closed. Then your GP surgery won't answer your question. There is no response. If it is regarding COVID symptoms, ring 111. Everything is, so this is a classic example of, withdrawing the strengths of the system and very perversely relying on the weaker part of the system, because 111, as we all know, with all its merits and with all its things, it is not equipped by doctors and fully qualified. We had to wait for 1 hour to get access to a nurse, only to be told that you need to isolate, you need to do the usual things. So I was living in a country where the healthcare system is not only inoperational for a few days, it's non-existing. I think, then I asked the question, I'm a doctor, what is happening? Can't a doctor, I'm not talking about individual people, it is the system, because can't somebody talk to us saying that okay, we don't know. See, we think our symptoms are very severe, or we may underestimate our symptoms. Because some people won't call for help soon. So there should be somebody who is able to triage at least and say, oh, this is very serious, you go. And luckily, one of my friend, because at that time, if I want to buy a pulse oximeter, the waiting time in the Amazon is 2 weeks. I can't even get a pulse oximeter. And one of my friend in America, she somehow got it to me in 2 days. That is also through Amazon. And that is a lifesaver. At least I was able to see what is the oxygen levels at what time, because I would have called an ambulance every hour. Otherwise, it looks so dire. So that is one major point. I gave this feedback to so many forums, that when we get a crisis, the system had to show leadership. The system have to stand. The system have to guide. It should not escape and run away. But again, compared to the second wave and the third wave, I think we are very robust now. And all these things I can say are rectified beyond. So I don't have any kind of complaints now, because I've seen how it operates, and in my own hospital I've seen. But that was the time, luckily, we were in the midst of things, and I had that personal experience. That was very scary. Yeah.
Thank you, Dr. Rao. So obviously you've experienced, and we all know, that the NHS was under significant pressure, especially during the first wave, and it still continues to be. So how did that experience affect your thoughts on going back to work in a hospital?
Yes, and then for 2 weeks we survived. I think by the end of 10th, 11th day, we started getting that confidence that the worst is over, and we went through. And it's almost like it sucks your energy. It almost like it's muscle wasting. The muscles are all wasted, and each of us lost 5 kilos in that 2 weeks. Very weak for another week, but I was able to go back to work on the first day of 4th week. So I think that really gave me a perspective, because I was never a patient before in this country. And for the first time, it's really an eye opener to see, because we sit in the doctor's chair and we say all the things, which we are supposed to say. But sometimes we do not feel what it really feels to the patient, what fears they experience from their point of view. I think it really made me, a better person. It made me a better doctor. And I was able to appreciate from their point of view. And of course, all that experience helped me to support my colleagues, to support so many other people. And I think I opened myself I was there in the social media and other media. And I was always kind of on the other end of the phone to just a few pieces of advice, a few words of support, and clearing their myths. Because a lot of the people who do not have a medical background, the main problem there is the myths. We need to clarify those myths, saying that, it's okay, this is the threshold, don't worry, you're not at there, and this is the way you need to access services. So I think I almost like dedicated myself for that, and I helped a lot of people, and that gives me a lot of satisfaction.
Thank you so much. Yeah, you have a really interesting perspective from being a doctor and also experiencing it so early on. So thank you for sharing. We're now going to move on to Medusa. Medusa is a physician by training and current MHA student. Medusa, are you there?
Yes.
Hi. So we wanted to ask you if you could cover your professional and personal experience.
Yes. First, I'd like to thank you, Sujata and Natasha and rest of the mentoring to giving me the opportunity for this event. And it was really great to hear all the other representatives. So I'm Dr. Medusa Vithanaj. I'm a mother of 2 little boys and a wife, healthcare advocate and physician by training. I work in the Long Island Jewish Medical Hospital, part of Northwell Health. We are the largest healthcare provider for the New York State. So as we reflect 1 year from the start of the COVID-19, the pandemic, I think we are undoubtedly in a very different place compared to all the unthinkable deaths and the illnesses from the pandemic. But I think the hope and the optimism is finally taking hold with the promise of the vaccines. So at Northwell Health, where I worked, I think we were very delighted the last year on the December 14th, when our very own, she's a critical care nurse, Sandra Lindsay, she took the COVID-19, the first vaccine. She's the first known person in the US to receive the vaccine. So I think it was a very significant moment for us. And in US, the Smithsonian National Museum of American History, they're going to hold some of the artifacts from that day. So including the first vial and her scrubs, and then some of the other artifacts from that day. I think part of the healthcare system, this was a very proud moment for us. And then I think for the leadership team at Northwell Health, we combat the pandemic during when we were the epicenter. It was really a difficult time. So I think moving forward, this would looking back, this would be a really great opportunity. And I think people would learn how this pandemic was and, how hard it was on, especially the healthcare workers and the families and all that affected.
Thank you, Medusa.
Thank you.
Thank you, Medusa. That was very good. We'll have a little break now. The students of Rekha Natya Academy are going to give you an insight of how they find their dance lessons in the lockdown. Mrs. Rekha Girish, are you there? Rekha, if you can raise your hand, that would be great. Rekha Girish has her own dance school called Rekha Natya Academy. It's one of the leading dance schools in Wales. May I ask Sangeeta to play the video, please? Thank you.
I've been learning Bharatanatyam, which is an Indian classical dance. As we all know, lessons are going and following through a new normal, through Zoom, of course, due to the unfortunate pandemic. This would, of course, make learning harder, as dance is a physical activity, and as you could see in the dance before, there was some lagging and confusion between lefts and rights. However, our teacher, Rekha has done a great job at structuring our classes so that no aspect of this learning of art is lost. and that we have the same positive and active attitude to learning this magnificence of Indian culture and dance.
Learning Bharatanatyam in lockdown has been really fun, sometimes a bit hard. We all had to adjust to the new reality, and Bharatanatyam is definitely a way to cope with the struggles and difficulties of lockdown. I always thought that Bharatanatyam was an art that couldn't be taught online or virtually, but this lockdown has made me realise that anything is possible with determination. I had to put a lot of effort into dancing and learning new dances, and I found it difficult at first because I was always used to being in the same room with my teacher, and I was more comfortable when clearing doubts with her, but now I feel a bit awkward when I have to ask online. But I've had to adapt to the new way of learning, which did take some time, and I do get confused sometimes, but I've learnt to be more comfortable when asking for help, and it's just a new way of learning things, and it's a really nice experience.
I really like dance and it really inspires me. It is an amazing thing to do and is really nice. It's fun and sometimes stresses me out, but mostly relaxes me. Our teacher, Rekha Auntie, is very nice. She helps us with our weakest points, making us stronger every class. The amount of work we have to do is overwhelming, but it's worth it. In lockdown, we have to do online classes, but I prefer this more.
Fortunately, we are able to continue our dance lessons over Zoom and progress. It saves travel time and we can learn from our own homes. There are some challenges such as technical issues and limited space. At times the screen lags, so it appears that we are dancing off the rhythm. It can be difficult to see our teacher clearly and get the same attention and feedback. Also, online school and dance increases our exposure to screen time. However, dance is fun and gives us a break from schoolwork.
I really enjoy Bharatanatyam because it keeps me close to my family heritage. It's a very expressive form of dance and is a good form of exercise. I'm lucky to be able to continue online lessons in the coronavirus pandemic because some of my other out-of-school activities have been shut down due to COVID. I haven't really been able to see my family and friends, so I really miss them, but I know that I'll be able to see them soon.
Quite an interesting journey, and it's also been difficult at times. I felt it has been difficult to adapt to at the start because I didn't know what Zoom was and how to use it properly. So it was difficult to understand and also use. And also, we had lots of issues including internet and slow connectivity, which made it even more difficult. But what hurt me the most was the fact that we couldn't talk to each other face to face anymore, and I felt that Zoom just didn't have that flair to it that we normally get. But otherwise, I'd have to say that this was a great opportunity because I had more space to dance and also less distractions, and that especially helped me
Thank you so much, Rekha, for contributing this video, and that shows how talented you are, and so are your students. Over to you, Siki and Natasha.
Natasha,
Our next speaker is Major Peter Harrison. Hello, Peter.
Hi there.
Major Peter Harrison has served in the British Army Reserve for over 30 years, his latest deployment being in the UK operations, providing support to the NHS and Welsh Government in the fight against COVID-19. My first question for you today is, you were involved in leading the whole town testing pilot in Merthyr Tydfil in Wales in November, December of last year, where there was a spike in cases. Could you tell us your role and how did you manage this project and what were the results?
Yes, first of all, I'd like to thank you for inviting me along to this evening, and I'd be delighted to talk to you about what we did in Merthyr Tydfil and how it achieved some marvelous success. So on Friday the 13th of all days of November, a small team of planners were pulled together from right across the UK. And I was put in charge, and the task was to introduce whole town testing to Merthyr Tydfil. Now, Merthyr is a small town in South Wales. It has a population of around about 60,000 people. So the challenge we had was to introduce the lateral flow device test, which is the 30-minute results testing kit, and to at least, we were told initially, about 10% of the population, and they were to receive at least 2 tests within that period of time. So quite a simple task at first glance, because 10% of 60,000, it's a very small number, and to get those people through shouldn't take too much time. The start time was the 23rd of November. Quickly that got changed to start on a Saturday, because it was felt that more people would probably come out on a Saturday. So it got brought forward to the I think it was the 21st of November. And then they increased it to, well, they actually wanted 90% of the population to be tested. So not including the children under 13 years of age. So very quickly, our parameters changed. So I split the team down into the first half of the team, myself and one other. We went to talk to the council officials up in Merthyr Tydfil to see what they'd already planned, whilst the other 2 in the team were sent off to look at the sites for potential testing centres. So that day, on the 13th, we arranged conversations with the CEO of the local the local authority. We determined that they had sufficient sites, and very quickly we determined that there would be no potential for military support in the early days. Now, you might remember that this was also piloted in Liverpool a couple of weeks before the Merthyr pilot was trialled. And there were some 2,000 soldiers were sent into Liverpool to assist with the rollout of the testing. There was no such luxury for Merthyr Tydfil, so we had to come up with a different way, a different model, and this effectively became the community testing model, which has been so effectively used across the whole of the UK. What's the difference, you might say, with community testing? Well, it's the community providing the testing for the people within the community. That has several advantages, which over bringing in unknown service personnel into a location that don't know the area, don't know the people, and perhaps don't know the cultures. Whereas within Merthyr, it's a very tight-knit community. Everybody, knows each other. Whether they're a family member living next door, down the street, across the other part of Merthyr, to very close friends. So the first thing we looked at was, well, we need to get all this stuff in from England to be able to set up. We didn't have any testing kits. We didn't have any sites. So the first logical thought was, well, how do you run your local elections? how do you run any election in Merthyr? So very quickly, the council realised that to set up a testing centre was very similar to setting up a polling booth and a polling site, utilising the booths so that you could do your test. And we set about the plan, we talked it through, and within days, the council had split out the different responsibilities. So the council already deals with road and traffic. So the roads department went out and put the bollards out, made sure that all the roads were safe and where the car parking was going to be. They also had a comms team. They were starting to put the advertising out that this was going to start and how much benefit it was going to be to people. They had everything, the works team that they could set up the testing booths. They had the equipment themselves. They utilized the tables, the chairs, and everything they had, the cones to make it what was an effective testing place. So as the days whittled away, we got ever closer to the start time. The biggest concern was, would anybody turn up? Because we'd heard what was happening up in Liverpool. People were turning, they would turn up, and there would be people coming around with loud hailers around in cars going, don't get yourself tested, you're making it worse, you're going to extend lockdown if you're going to get yourself tested. Oh, and by the way, there's soldiers here, you don't want to be tested by a soldier, because why would you? And people were discouraged from getting tested. So we had all this noise coming from Liverpool, and we thought, well, let's put a bit of faith in the people of Merthyr, and let's see what happens. So it opened up, and literally there was a queue of around about 200 people on day one. The people who were the real heroes of this are the people who worked in the leisure centres, because they volunteered to become the testers, and great community spirit. So the advantage of that was that they knew the people. So when the queue was getting long and people were getting cold, they were able to go out and say, hello, how are you? You know who I am, and it instantly put people at rest. So that was the sort of the challenge. That's how we overcame it, and actually, it's one of the best collaborative bits of work I've seen. So you had the Welsh Government, you had NHS Wales, Public Health Wales, you had the local authorities, and you had the local health board, Cwm Taf Morgannwg, all pulling together to make this work. And on the day, the police force, third sector organisations got involved as well to make sure that everybody understood what was going to happen. So the pilot was supposed to last for 20 days. They decided that they would go for an extra 5 days, so 25 days in total, and they broadened the reach of the pilot into the Lower Cannon Valley, which comes into a different local authority area next door to Rhondda Cynon Taf, but it's still in the same health board area. So in total, they tested somewhere in the region of 45,000 people in the 25-day period, which is quite remarkable considering in the Liverpool model, I think they only managed to test around about 15% of the population, whereas in Merthyr, it was almost 50% of the population that came out to be tested, and more than once. And in Merthyr alone, they found over 700 asymptomatic people, which is absolutely brilliant, because it was not long before Christmas. The results from that were the people all self-isolated. And we know that one contact or one asymptomatic person taken out of the circulation within the population will have a massive effect. Imagine taking 700 out of the population. all self-isolating, the effect that had. So the effect it did have is that, and you can measure it because Cwmtaf Maganwg has Bridgend, Rhondda Cynon Taf, and Merthyr under its control. There was no testing at all in Bridgend. There was a small amount of testing in Rhondda Cynon Taf, and of course we did the whole town testing in Merthyr Tydfil. The spike that most people experienced just after and around Christmas didn't happen in Merthyr at all. And when you put the three graphs of the three local authorities together over the same time frame, you see a marked difference. So Merthyr went from I think it was the highest number of cases of COVID per 100,000 in the whole of the UK. After a 2-week, 3-week period, it went down to one of the lowest in the UK. So that was the experience. It was really good to be part of, but it was great to see the community of Merthyr Tydfil pulling together and achieving that success. I hope that answers your question.
Thanks, Peter. Since it was so successful in Merthyr, do you see this like community town testing becoming the future as we see more variants and local spikes?
I think what did happen was that the model of community testing was seen as a way forward, and as a result, we were talking to local authorities right across the UK. We spoke to Greater Manchester Council, we spoke to Hull, Leicester, Nottingham, plus many more about how Merthyr achieved what they did. So that model was adapted and taken right around the UK. So whether it'll be the way forward, whole town testing probably isn't, but I think the lateral flow device has a part to play in identifying people early on. Mm-hmm. And taking them out of the system so that they're not able to be spreading COVID, because it is what it is. It's an asymptomatic test, finding people who are asymptomatic, people who don't know that they've got symptoms, and if you can stop them from going shopping and going to work and spreading, then you're going to make a big difference. So they've reintroduced it into Rhondda Cynon Taf, Bridgend, and Merthyr for a month, and already they've tested. I think this is more targeted tested. It's targeting areas of deprivation, targeting areas where they know that perhaps COVID is lurking, and they've already done around about 4,500 tests and found I think it was about 9 or 10 people within a week period. So whilst those numbers are low, we are, the numbers of COVID are low as well, but it is saying that it's still out there. They're finding, 10 cases. Those 10 cases will very quickly spread. So whether it's the future, it's part of the future. But I know that we're getting used to the click and collect model, and lateral flow devices, don't be surprised you'll get a click and collect or a delivery to home, because eventually we will all have to get used to having at least 2 tests a week to sort of show that we're clear of COVID, very similar to what the teachers are doing now and what the school children will do. Hopefully that helps.
Thank you, Peter. Dr. Alan Duff will be leaving us shortly. Just wanted to check if anyone else has any questions for Alan today.
I have a question. If nobody is taking. Being a science journalist, what's the difference between a science journalist and just a journalist, a news or a reporter?
Most people who specialize in science journalism have a background of some kind in science. It may be just an undergraduate degree, or in my case, did a PhD and then decided they wanted to be a journalist. But people who are a little more focused manage to make that decision earlier in life. So it's really traditionally, I mean, it was just something that a journalist might end up specializing in as they covered those types of stories. I think now it's become a much more specialized type of activity. I'd say the majority of science journalists I know and have met have some kind of a background in the sciences and then pursued it from there. I think you're muted.
I've got a question.
Sorry.
Suji, I've got a question to ask.
Go on.
Sorry. To ask Dr. Duff and Mr. Barnard, every time we hear about a mutation, it seems to be more potent than the original. Do we have any knowledge of viruses, in effect, mutating themselves out of existence?
No, but so first of all, the variants that are being discussed, there's a lot we still don't know. I know some of these variants have been discussed as highly transmissible, which is a term that when it started being thrown around early on, I was very annoyed about because the early data didn't support that. And I still wouldn't necessarily call most of these variants highly transmissible because we still don't know if there's a difference. When in virology, when we talk about transmissibility, we're talking about the virus actually making the trip from one host to the next. The term that we've been trying to put forward on the TWIV podcast is fitness, viral fitness. There is accumulating evidence that some of these viruses are fitter than the established, what I might call the wild type virus, in the sense that they are displacing other variants from the circulating population. There are a lot of ways that could work. It's not necessarily about transmissibility. It might be, for example, that the virus has a longer asymptomatic phase or pre-symptomatic phase, which would mean people would spend longer out and about spreading the virus around. And that's not really about the transmissibility part, but it would make the virus supplant other strains in the population. So there is that issue. What we generally see with viruses when they mutate is that they will mutate in ways, like all life, that will make them more fit, that will give them some kind of an advantage. So it is not surprising to see variants emerging that will supplant other variants. We do see some examples of viruses mutating in ways that may affect their pathogenesis, or what we see more often is the end product of that. So we'll see differences in pathogenesis of virus within the same family based on their route of transmission or their other aspects of their biology. But in all cases, it's explainable as being that the virus has changed in a way that made it more able to perpetuate itself. So ultimately, I think with these variants, it's important to keep an eye on them. I don't necessarily think we should be running around with our hair on fire about them, as some people have, but they bear watching, and I don't think we're going to see the virus, unfortunately, mutate itself to extinction. What we may see is it mutate itself to greater attenuation. So that it is a less severe disease that spreads more easily is one possibility. But again, we still don't have a lot of good data on exactly what these variants mean.
Thank you.
Thank you, Alan. I don't know if you have time for one question from Colin Gill.
Sure, I can take another.
Sorry, I was just about to say that your very last statement there answered my question. The last time I studied virology was as an undergrad, so it's a very long time ago. But as I understood it, even though the virus mutates, it will still be around And so my question was, even though we've got all this vaccinations going in process now and the numbers are very low, in years to come, so every time we have seasonal flu, like Christmas time, will we see another variant of the virus, and will it be as serious as the ones that we've had thus far? But you answered the question by saying that the attenuation diminishes as the time goes on. So I think you've answered it already.
Well, in fact, we have 4 great examples of viruses that have followed this pattern. There are coronaviruses have been circulating in humans for a very long time, and you've had them. There are 4 different strains of circulating coronaviruses. 4 different species of circulating coronaviruses that go around as common colds. So you get the sniffles, you get over them. You never give it a second thought. You had a common cold. It could be a rhinovirus. It could be a coronavirus. So these 4 coronaviruses that cause common colds have been doing this for centuries. They circulate in the human population. They accumulate some amount of variation that allows them to just evade your previous immunity to them enough that they can reinfect. And then you get another cold, and then you wipe them out. So I think what's happening is we are witnessing a 5th human coronavirus making the transition from animals into humans. It is entirely possible that something similar to the COVID-19 pandemic occurred with the previous ones and just nobody noticed, because this happened in earlier centuries when somebody dying of respiratory disease at age 70 was not of any particular note. Well, 70 years old, who lives to be 70? So this may just be the normal thing that coronaviruses do every now and then, but we've noticed because we actually are paying attention and noticing, wow, that's a lot of people dying. And they're, we don't have the background of death from all the other diseases that we've brought under control. So I think we're going to get to a point where, yes, we have SARS-CoV-2 just circulating in the population, and it just joins the other coronaviruses and becomes nothing particularly worrisome.
Thank you, Alan, and thank you for your time today during this event. So now we're going to move on to John Gamblin. John is a founder member and a trustee of TMR. He now lives in Cornwall, but is still closely involved with the charity. And unfortunately, John has lost 3 friends during the pandemic, which has no doubt been very challenging. Hi, John.
Hi, Suki. Yeah, I think that's what I can really say is that from a personal point of view, losing 3 close friends makes this so difficult. And for every death, there's a family to consider. A lot of people have got their spouses, children, grandchildren. So it has this ripple effect right through communities. As you say, I live in Cornwall now, and it's been very light touch here. We haven't had that many cases relatively, but I come back to Wales very often, and it's interesting to see the different attitude in communities in Wales and in Cornwall. Wales now take it very seriously, and Cornwall still have this attitude, well, it's not going to happen to me. But I was shocked when I came back down here just before Christmas, just before Wales locked down, to actually get it just after Christmas, in fact, early January. And I'm still suffering 2 months on. I'm more or less back to normal, but I've still got issues with tiredness and respiratory problems. So by talking to people here, I think it does gradually filter through that this really is a much wider problem than just seeing the statistics on the TV and people talking, the clinicians about the clinical problems. So yeah, it's from my point of view, it's the human side of it, which is important. And it's very important to have forums like this where we can discuss the problems and what can be done about it.
Since you did lose 3 friends, how did you feel when you contracted the virus?
Well, I was shocked, to be honest, because losing people close to you makes you very cautious about the way you live your life. And I became a hermit practically for a few weeks. The only time I went out of the flats that I've got in Cornwall was to go to a supermarket, and I'm convinced I picked it up, which just shows how easy it is. So, yeah, my initial reaction was, can't be. But when I got the test and started going downhill, I realised very, very devastating virus this. So yeah, it was tough. Yeah. So my message, I think. Sorry, Natasha.
Sorry, John. What are you looking forward to once things goes back to normal?
Well, I think quite a few people have said that they're missing face-to-face contacts, and I really miss that. I miss working in a museum that I'm closely connected with. Can't wait to get back to that side. I'm heavily into art in groups, so I want to get back to that face-to-face contact. So they're the biggies. But I think my final message would be to people to get vaccinated. For now, keep the social distancing, washing their hands, and it's all very tedious. But unless people do that, we're never going to get to the end of this road. No pandemic's been killed off without some form of vaccination program. So I think that's the key from my perspective.
Thank you.
Thank you, John. We now invite Donna. She's one of the friends of the TMR, and Donna is going to share her story. Over to you, Donna. Do you want to unmute yourself, please?
Sorry. Just getting used to technology. So can you hear me?
Yeah, we can.
Siki.
Good.
We'll be talking to you now.
Okay. Hi, everybody.
Hi, Donna. So firstly, we just wanted to ask, how did your previous health conditions impact you during the pandemic?
Well, quite greatly, to be honest. I'm recovering from a condition called autoimmune limbic encephalitis. So that's brain inflammation. So I'm on all sorts of medication, and so I went straight onto the shielding list. So I was doubly having to stay inside. So nobody could come out. I couldn't even be naughty and go anywhere because everybody who knows me knows what's going on. So so basically, the biggest thing that happened was all my sort of support services had to stop. So I was having rehabilitation help from the local, we call it like a brain rehabilitation unit. So I was going there 3 days a week to have, more case of memory help and physiotherapy, occupational therapy. I was going down there and group therapy mainly. I was doing art. Art is listening to what John just said, and art is fantastic. And I also miss my art groups. So that's been the main thing. It's been the stop of services. So I've had to kind of rely on myself and go back in with, my own sort of strengths. And yeah, that's mainly been it.
Thank you, Donna. I've got a question for you. So we've heard that you've achieved something during lockdown. We would love to hear more about what you achieved or stated during.
Okay, well, to explain the Donna Flame Brain name, I created an online personality, mainly to bring awareness to my condition. Encephalitis is still quite a rare known condition, and especially with the autoimmune case that I have. So I've been doing sort of videos online and that to to kind of, yeah, to show my life and my progression and my positivity with recovery. I have to laugh at myself a lot because, you know, I get a lot of things wrong these days and my memory is awful. But the main thing I can do is just be happy. So with that, I thought, what can I do now? Because I got itchy feet and itchy hands. So I thought, what can I do? So I thought the main problem I have now is memory issues. Okay. So I thought I'd develop something based around memory issues. So I've come up with my own little business and I've chatted with my mentor at TMR. And now I'm in a position to move forward and progress my business and my ideas, which, you know, we all agree that it's quite a good idea. So I'm not going to stop with this. And so with TMR support, my fantastic mentor, I'm in a good place. I'm in a good position to move forward with my idea, which is basically, it's sort of like a jewelry memory collection to help people like myself with memory problems. But, you know, we can have jewelry and beautiful sort of pieces on our arms and neck that kind of in there is sort of personal information, names, numbers and stuff and these are sort of gifts and things you can give to people with memory problems, people with dementia, people with all sorts of problems. Again, like myself with functioning brain injury, you know, little gifts that, you know, I kind of forget where my husband's necklace come from or whatever, but this, you know, these pieces will tell stories. So I'm so excited. So yeah, so that's what I've been doing. So that's why I'm excited to be here to tell you all about it.
Very exciting, and it's good that you've got something productive and exciting to do during lockdown whilst everyone's just sat inside. Yeah, we can't wait to hear more about what you do in the future. Keep us posted. So now we're going to move on to Colin. Colin Gill has been a sport and health coach for over 20 years and is recently delivering a variety of online activities with TMR. Hi, Colin.
Hello. Thank you very much for inviting me along.
No problem. So first we wanted to ask if you could tell us a bit about the community health interventions that you've made over the last year.
Sure. I thought that I would actually start off by just giving a little bit of background about me. My postgraduate studies was in exercise, nutrition, and public health. And a lot of my course mates, they went on to work in the public health field, writing up policies and strategies for local councils or NHS trusts and things like that, in order to try and encourage the community to live healthier lives. But with that qualification, I felt I wanted to be a little bit more hands-on. I wanted to, I'm a doer, so I wanted to actually get on the grassroots level and physically encourage people to live more active lives. And so I set up the Brave Lifestyle, which is a company that I use to do community health interventions, a variety of different fun ways to exercise. So I was going to share my screen, but it doesn't seem to want to let me do it. I was just going to show you guys a few of the things that I came up with. Thank you, Siki. So one of the things that we set up was a cycle club. So I would take people on guided rides in Swansea, Cardiff, and Bristol, so that they can get out and be more physically active. A lot of people don't like gyms, they find it very stuffy. And so engaging them in a variety of different ways with these community health interventions, I found to be really useful. I did things like outdoor gyms. We'd do a little gym session by the beach or by a picturesque lake here in Swansea. And it seemed to work really well. People were really engaged. But then COVID hit, and it meant that I had to find a solution that allowed me to still engage with people in the community without physically being present. So one of the things that I was doing before lockdown was something called Sports Acro. It's a combination of yoga with acrobatics, and I put my little bit into it and turned it into an exercise class. It's really good for building people's self-confidence, empowering them. They learn to communicate better with each other. At the end of the session, you end up thinking back to yourself, how did I manage that? And people were really enjoying the sessions. They found it really enjoyable. But then lockdown happened and we couldn't do it any longer. So I took it online and used Zoom as a platform to deliver other types of community health interventions. This one that you see here is called Parent and Child Acro. So we got parents and their children to play together. They were all homeschooling anyway. And so for half an hour, 2 times a week, the children could put the books down and interact with their parents in a fun way, whilst getting the exercise benefit of it as well. And so really impressive stuff. You'd be surprised what you're capable of when you put your mind to it. And the kids really enjoyed it. As we're easing ourselves out of lockdown now, I'm hoping to do a lot more of the acro stuff outdoors. So I'm just waiting for the government to say that that's okay. And then we'll be doing outdoor sessions like this in picturesque locations around Swansea, Cardiff, and Bristol. As well as the exercise and the acro, I teamed up with one of your volunteers there at TMR. Her name is Gerda. And we know each other from the local salsa dancing scene. And because we both have that as a common interest, we decided that she would do some learn to dance salsa classes to people online. And so I shared my knowledge with her, and she delivered her classes. And as far as I know, it's still going strong. Everyone seems to be enjoying what she does. So I think the take-home message is that even though we were doing stuff before lockdown that had suddenly come to a stop, it's not about giving up. It's about finding a way around the obstacle. And as long as you're creative about it, you can come up with lots of different ingenious ways of engaging with people in the community.
Thank you, Colin. Thank you very much. That was interesting, how you're connecting with the community and how community has had an impact with not just young people, but everyone, and as well as families. I loved it. Thank you.
Thank you. So our next speaker is Dr. Alka Ahuja, who's a consultant child and adolescent psychiatrist at Aneurin Bevan University Health Board. Her areas of interest include neurodevelopment disorders and user and carer involvement in health services. Hello, Alka.
Hi, can you hear me?
Yes.
Yes, we can hear you.
So we heard that you were awarded your an MBE for your services to the NHS during COVID-19. Could you speak a little bit more about what you did and how this came about?
Thanks for giving me a chance to share my experience. I was working in Gwent on a project called Kuch, which was offering video appointments to children and young people who were referred with mental health difficulties. So those with self-harm, eating disorders, they would be offered a video appointment in 2019 when it was considered very innovative, although this has become everyday practice for us now. And we were evaluating that. And last year, exactly coming up to a year now this week, Welsh government got in touch and said that they were going to use Kuch as an exemplar to roll out video appointments across Wales, because obviously with the pandemic, the worry was that we needed to continue providing care in a safe and timely manner to the public of Wales, but also protect the NHS workforce, because a lot of people were self-isolating, a lot of them were COVID positive, and it was making sure that we could reach out to the vulnerable, those who were shielding. So we started the rollout in March with all the GP practices, and within weeks, we managed to provide video appointments to patients in 90% of the GP surgeries. This normally would have taken years to happen, but obviously with the pandemic, with all the red tape cutting down and people's mind shifted, changing overnight, it was achievable within a couple of weeks. We then moved on to providing hospital appointments, secondary care, appointments with therapists, but also connecting people who were admitted on the COVID wards and intensive care with their families virtually. And for some of them, it was quite hard because it meant saying their final goodbyes. Providing care home staff and residents contact with the healthcare workers so that they could continue to provide care to them, because these were the most vulnerable people and visitors were not allowed. So nobody was allowed to go and see them if there was anything that was needed. And then moved on to dentistry, optometry, pharmacy, evaluating the program, making sure we were learning from feedback. And we've consistently found that patients and clinicians rate it very high. It's 92%. And we're hoping that with all the savings that we've made in terms of time, travel, and carbon footprint, it'll be something that we can take forward as we come out of the pandemic.
Thanks, Alka. In your interview with The Guardian, you mentioned that post-COVID, the healthcare landscape is going to change. Can you expand on what you think the biggest developments will be?
I think having lived through the pandemic, we have learned a lot, and it was holding on to the lessons learned. Technology has been embraced. People's mindset, as I mentioned, has changed. We're getting better using video appointments. I'm not saying it's going to replace everything we do face-to-face, but with the increasing demand on the NHS, it may be a blended approach where some people, it may be convenient to offer video appointments, whereas others may need face-to-face appointments. Online help is available. There are websites now such as Silver Cloud, which can be accessed to provide therapy to those who may be having anxiety and depression. There are apps which are being evaluated, because we've got to be mindful whatever we use has to have evidence. We've also realized the impact on the planet, traveling for appointments, the carbon footprint, how much has been saved in terms of that. But I think for me personally, what I've found is that organizations and individuals are becoming more aware of the mental health and well-being of the workforce. We've never thought about it that much, because if you think during the pandemic, people overnight changed roles. People took on leadership roles. They had to develop new skills. I've got colleagues who were working in mental health and were posted in intensive care wards and COVID wards, learning to prone patients, learning to intubate, learning to do things that we learned as medical students but hadn't done it for years. And I think it's had an impact on each and every one of us. But moving forward, it's thinking of how we deal with that and how we support the workforce, and being mindful that things that we've started doing in hospitals, such as mindfulness on a Monday, well-being Wednesday, we hold on to that. Those conversations which we have, we think about each one's well-being, and it's something that's going to be very important if we want to look after the public and the workforce as we go forward. One thing that the pandemic has taught, that it was a big challenge, but it managed to get the world to stop. And I think we've stopped, and it's our chance to reflect and take all that we've learned forward. Otherwise, it'll be a loss in terms of what we have achieved in the last 9 months.
Thank you, Alka, for all your hard work and sharing your story with us today.
Thank you.
Our next speaker is Teresa George. Teresa is a founder of Alopecia Supporting Unit. Hello, Teresa. Teresa, are you there?
She's not there, I think, is she?
I don't think Teresa's on.
I saw her. Okay, we'll move on to the next. Is Chanda Chadha there? Chanda?
Yes.
Yes. Shall we?
Yes, I'm here. Yes.
Chanda, over to you. How did the lockdown had an impact on you or your?
Yeah, I've made some notes, but mainly it affected on two levels. One is family level and professional level. Although I'm retired, on the I do a lot of voluntary work with a couple of organizations, and my thanks to TMR, who were my first port of call for my voluntary work and things like that. All I've learned is through TMR. And now, having retired 15 years ago, with the help of TMR, I was engaged in voluntary work, looking after people, older people, young people, providing help. And then I went back into employment, and now I do voluntary work. But the voluntary work is made it very difficult to meet up, although I'm providing telephone support. But to give you an example, recently I was talking to somebody, I'm giving telephone support, and I shouldn't say the poor lady, the elderly lady who is a little bit older than myself. She needed help with something the carers hadn't done for her in the morning. And because of my involvement through Age Connect, there's certain things, you know, we cannot do. I could not visit her and provide her the support. It was very, very hurtful and depressing, and sort of punishing myself. Why can't I go and do that? You know, if somebody falls on the street. But all this COVID situation has made it so much difficult, you know, providing help face to face or having physical contact. On family level, it's been difficult because I am a grandfather, and with 7 grandchildren of various demands, it's been very difficult to look after them, and having a supportive wife has helped us manage that depression levels we go through. They get very emotional, although you cannot show that sort of emotion to your children, who come up with you know, little questions like, Nana, why can't we see you? And they understand COVID is a virus which stops people getting together. But, you know, it's so difficult. And on the other hand, talking to them on the Zoom has made it very, very easy to see them and for them to see. But it is, the worst part is the emotional side, not being able to hug and kiss them. To give you an example, our daughter came from Saudi Arabia, where she's gone for a couple of years. She came home and we couldn't touch them. We had to isolate upstairs into our rooms. We had to distance ourselves, abide with all the rules and everything until the tests came back, and we could hug them. And it's sad, and it's sad in some points, good in other points. There's been positive aspects of it and negative. Positive is that I've caught up with a lot of work, computer work and things like that, sorting papers. On the negative side is the physical distance, which has kept us apart, and sticking to the rules is very, very important. If I was to say it to anyone, COVID or no COVID, you got to believe in what the public health people are telling you, you know, like washing hands, keeping your distance. That would be the one thing I would recommend everybody to do, no matter how trivial you might feel. So this is why I have little contact with the community. Whenever we go shopping, we make sure we go early in the morning when it's quieter in the shops. But very important to follow the rules and regulations to keep not yourself safe, but other people safe.
Thank you very much, Chandra. It was lovely having you.
Thank you.
And is Hazel there? Hazel wanted to speak, or Lucy?
Oh, hi. Sorry. I'll speak if you wish.
Hi, do you want to? Yeah, go ahead.
Okay. What I found about lockdown, obviously I was recovering from illness because I came out of hospital well over a year ago. And I got all the things what one normally does. I went and did my month's shopping and everything. And then we had lockdown. And then what I found, the effect on me, from that point of view, over the period of time, I've had to change my way I get my stuff, that my food and things like that, because I wasn't really allowed out. The positive real side of the lockdown, I've fully recovered from what was wrong with me, because after I've been to South Africa, I came back with pneumonia and everything, and I fully recovered from that, so I'm quite fit in that respect. Negative side of it, things I was doing, it affects everybody around the world, so it's sort of slowed everything down. and people couldn't travel where they're supposed to travel, and it's caused a lot of problems, like your business, whatever you're doing, it's like put on hold. And then the next thing you hear them, they've got COVID-19. So that's been put on hold. But now things are beginning to move, right? And obviously then somebody died. These are the problems we've had, obviously, when you're doing business. This is what usually happens. But the real positive side of it is I met, it was through a professional network, and I've ended up by September and got married. So really, lockdown has been very romantic for me. I've been very happy. But you know, my father-in-law was buried today because sadly he died. But I got to know him. Had a year to know him, so from that point of view, I've been reviewing everything about my life, about relationships, and people around me. They started creating, do the decorating, do those jobs they couldn't do before. And everybody seemed to be discovering things they forgot they could do. And one of the things I found, I've stood back and I said, no, I'm in control here. And I've switched off. And first time in my life, I've been switching my phones off. I've not played my music all the time and things that I always used to do. And I've noticed a big change in me. And we sit here in silence beside all the workers around here, bang, bang, drill, drill. Otherwise, it's been silent. So from that point of view, I find it's been very positive, and I can see a really good future.
That's good.
Opportunities
That's
as
good
well.
To hear. That's good to hear, Hazel. Congratulations on your marriage.
Right.
I hope you join your husband soon. And thank you all for joining and taking part in this event. Thank you to everyone who opened up to talk about sensitive personal stories like Hazel and others, and to those who shared the positives that came out of the pandemic. The world has come together as one community, united in the fight against COVID-19. If you have any feedback, please email us. Stay safe, and let's all work together to end the pandemic. Good evening.
Thank you, everyone.
Thank you, everyone. It was a pleasure to speak to you all.
Thank you. Bye-bye.
Thank you, Sophie.
Thank you. Well done.
Bye. Stay safe.
Thank you.
Thank you, everyone.
Thank you. Bye.
Thank you. Bye-bye.
Yeah, we will stop recording now. And is there anything?
Bye, Sujata and Natasha.
We can network if you